Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome back to the deep dive. Today, we are wading into territory that I think makes a lot of surgeons, even, the experienced ones, a little uncomfortable.
I would agree with that.
We're used to very binary problems, right? There's a tumor, you cut it out. There's an obstruction, you relieve it. It's plumbing.
Right.
But today, we're talking about intestinal failure, or IF. And the first thing that really hit me when reading through these guidelines is that IF isn't actually a disease. It's not a pathology you can point to on a slide.
It really isn't. It's a functional state. And that requires a massive shift in mindset, especially for our surgical colleague.
A huge shift.
The ESPN guidelines, that's the European Society for Clinical Nutrition and Metabolism, they don't define it by what the anatomy looks like. They define it by what the anatomy can't do.
Right. The definition is strictly about the consequence. They state, IF is a reduction in gut function below the minimum necessary for the absorption of macronutrients, water, and electrolytes, such that intravenous supplementation is required to maintain health or growth. So effectively, if the gut goes on strike and you need a vein to keep the patient alive, that's intestinal failure.
Precisely. Doesn't matter if you got there via a volvulus, Crohn's disease, a mesenteric infarct, or, a surgical complication. The destination is the same.
And for the doctors listening, understanding this functional classification is the difference between saving a patient and accidentally making things much, much worse.
It absolutely is.
Which brings us to our mission today. We are breaking down the management of IF for the clinicians in the room, from that ICU crash to, long-term home care. We're going to look at the 3-type classification system and specifically the surgical strategies that go with them.
Yep.
But before we dive in, I have to drop the mandatory disclaimer. Everything we discuss today is for reference and educational purposes only. Medicine is local.
It is.
Please follow your local guidelines and protocols in your actual clinical practice.
Absolutely. Think of this as the map, but you still have to drive the car according to the road rules where you are.
Okay, let's unpack the framework. The literature categorizes IF into 3 distinct types. It's all based on onset, metabolic stability, and reversibility. Let's start with type I. This seems like the bread and butter scenario.
It is. Type I is acute, it's short-term, and it's usually self-limiting. If you are a general surgeon, you see this weekly, it's the patient who had a major laparotomy and develops a prolonged postoperative ileus.
Right, or that severe pancreatitis patient.
Exactly. Their gut has, for all intents and purposes, temporarily shut down.
So functionally, they are in intestinal failure because they can't absorb anything by mouth.
For a few days, maybe a week, yes, they need IV fluids, maybe some electrolyte replacement. But here is the critical distinction. The condition is reversible, and usually the gut wakes up on its own.
What I'm getting from the sources, though, is that the danger here isn't necessarily the condition itself. It's the clinician's reaction to it. There's this urge to fix it.
That is the trap. In type I, the management is supportive. You decompress with an NG tube, you optimize electrolytes. Hypokalemia is a classic ileus driver.
Sure.
And you get them moving. But you do not operate. Unless you have clear evidence of a mechanical strangulation, taking the type I patient back to the OR is usually a mistake.
They're just chasing shadows.
You really are.
Yeah.
That old saying, don't just do something, stand there.
In its case, yeah.
Support the physiology and wait. But if that condition persists, or if we're dealing with a catastrophic event, we graduate to type 2, and this is where the game changes completely.
Type 2. The sources describe this as the interface of emergency surgery, critical care, and IF medicine. So this isn't just a sleepy gut anymore. This is a war zone.
It's a metabolically unstable patient with a prolonged acute condition.
Yeah.
We were talking about the patient with an anastomotic leak that has turned into generalized peritonitis.
Or the open abdomen patient.
Exactly. The open abdomen with exposed bowel. Or someone who has had massive resections for ischemia and is now septic. These patients are they're incredibly sick.
They're septic, malnourished, leaking fluid everywhere. The management strategy here has this great acronym, WESNAP, sepsis, nutrition, anatomy, plan. But the order is non-negotiable, right?
The order is everything. S in sepsis, it is the #1 driver of mortality. If you have undrained collections or an uncontrolled source of infection, it does not matter how good your nutrition plan is.
The patient will die.
The patient will die. You have to stabilize the ship first.
So drain the abscesses, get the antibiotics right, then you move to N nutrition.
And this is tricky in type 2. These patients are so catabolic, they're just burning through muscle and fat to fight the infection. You need to start parenteral nutrition PN almost immediately because the gut can't handle anything.
And what about all that fluid loss from, say, a fistula?
That's a huge challenge. You're constantly chasing electrolytes and volume. It's a real balancing act.
Okay, so then comes A for anatomy and P for plan. But I want to circle back to the surgical strategy here. There's a concept mentioned in the literature that sounds, frankly, terrifying. The hostile abdomen.
It is a visceral term for a reason.
Yeah. Can we dig into the why of this? The guidelines say you generally shouldn't attempt definitive reconstruction for at least 3 to 6 months. That feels like an eternity for a patient with a bag or a fistula.
It does.
So why can't we just go in, trim the bad edges, and sew it back together once the sepsis is gone?
Because of the biology of the peritoneum. After about 10 days, and lasting for months, the abdomen enters an obliterative phase. The adhesions aren't just filmy bands you can snip.
No.
They're vascularized, dense, almost concrete-like tissue. The bowel loops are fused to each other and to the abdominal wall.
So if you try to dissect that...
You lose the plane of dissection.
Yeah.
You can't find it.
Yeah.
You aren't separating tissues. You are tearing directly into the bowel wall.
You go in to fix one hole and you leave with 4 new ones.
Exactly. You turn a manageable situation into an enteroatmospheric fistula, which is an absolute disaster.
So the wait rule isn't just about letting the patient get stronger. It's about waiting for the cement to turn back into sand.
That is a great way to put it. You are waiting for the adhesions to mature and soften. The hostile abdomen eventually becomes friendly again, but it takes months. And that discipline to sit on your hands when a patient is miserable and leaking is one of the hardest skills for a surgeon to master.
I can imagine.
Yeah.
Okay, so we adhere to the SNAP protocol. We control sepsis, we feed them via FU, and we wait out the hostile phase. Eventually, the patient stabilizes, they aren't septic anymore, they're home. But they're still tethered to an OFI pole.
And now we're in type 3.
Type 3, chronic intestinal failure.
This is a stable state. The metabolic chaos is gone, but the gut simply cannot sustain the patient on its own. They require long-term home parenteral nutrition or HPN.
And the main culprit here is short bowel syndrome, right? SBS.
Usually, yes. It's the aftermath of those massive resections from Crohn's, trauma, vascular accidents. But, and this is important, it can also be functional.
What do you mean?
You can have a patient with a full length of bowel, but severe dysmotility effectively makes it useless. The plumbing is all there, but the pump is broken.
The focus here shifts from saving a life to rehabilitating a life. And this is where the medical management gets really interesting. The sources highlight GLP-2 analogs, specifically teduglutide. Is this just like a vitamin boost, or is there a real mechanism at play here?
Oh, it's mechanistically fascinating. GLP-2 is a naturally occurring growth factor. When we give an analog like teduglutide, we aren't just helping absorption. We are physically altering the structure of the remaining gut.
How so?
It promotes mucosal hypertrophy. It makes those little finger-like projections that absorb nutrients. It makes them grow taller. It makes the crypts deeper.
So if the gut is a shag carpet, you're basically making the shag longer.
Exactly. You are increasing the absorptive surface area without increasing the length of the tube itself.
And what does that translate to for the patient?
Freedom. We see patients who are able to reduce their PN volume by 20–30%. Some could drop 1 or 2 days of infusion a week.
Wow.
For a patient who is hooked up to a machine for 12 hours a night, getting a dry night where they aren't tethered to anything, that is massive for their quality of life.
That's incredible. But let's talk about the surgical side of type 3, because even with drugs, some patients need mechanical help. The goal is autologous gastrointestinal reconstruction. That's a mouthful.
It is. We call it AGIR. And really, the goal is to maximize the efficiency of the bowel you have left.
And the most obvious first step is just restoring continuity, reversing the stoma.
Always the first step. If you can reconnect the colon, you do it. The colon is a sponge. It absorbs water and electrolytes like crazy.
And if you have the ileocecal valve...
That's gold. It acts as a brake, slowing down the transit of food so the small bowel has more time to do its job.
But what if that's not enough? What if the bowel is just too short? The sources detail 2 very creative procedures. The Bianchi and the step. These sound like high-stakes origami.
They are. These are lengthening procedures, but they are only for a specific type of patient, one with dilated bowel.
Right, because the bowel adapts by getting wider, but that actually hurts the flow, doesn't it? It just becomes a stagnant pool.
Correct. So the Bianchi procedure involves taking that dilated tube and splitting it longitudinally right down the long axis. You separate the two leaves of the mesentery, create two narrower tubes, and then sew them end to end.
You're slicing the blood supply in half. That sounds incredibly risky.
It is. It's so technically demanding.
Yeah.
If you damage the vascular pedicle, you lose that segment of bowel. And remember, this patient doesn't have any bowel to spare.
Right.
That is why the Bianchi has largely been superseded by the step procedure.
The serial transverse enteroplasty, the zigzag cut.
Exactly. Imagine taking a wide ribbon and using a stapler to make cuts from alternating sides. You create this zigzag channel inside the bowel.
Like the queue line at airport security.
Perfect analogy. By forcing the food to wind back and forth through that zigzag, you increase the transit time. You make the stream narrower and longer.
And the advantage over the Bianchi.
It's technically easier, though still very complex. It preserves the mesentery better. And crucially, if the bowel dilates again over time, which it can, you can actually do a step procedure a second time.
You can't redo a Bianchi.
You really can't.
That brings us to the end of the road, the final option, transplantation. The sources frame this not as a cure, but as a rescue.
That is the right way to view it. Intestinal transplantation has improved significantly, but it requires heavy, lifelong immunosuppression. You are essentially trading one chronic disease, intestinal failure, for another one, transplant recipient.
So you reserve it for PN failure.
You do.
PN failure sounds a bit vague. What does that actually look like clinically? Are we just talking about running out of veins?
That's a big part of it. Loss of venous access. If a patient has thrombosed their subclavian, jugular, and femoral veins, you physically have nowhere to put the line to feed them. That is a hard stop.
And the liver plays a role here too, I imagine.
Yes, I-fold intestinal failure-associated liver disease. The liver just takes a beating from chronic PN and the lack of gut cycling. If you see the bilirubin rising, platelets dropping, and signs of cirrhosis, you are running out of time. That is when you call the transplant center.
It's a sobering reality. It really emphasizes why that whole rehabilitation phase is so critical to keep them away from that cliff edge as long as possible.
Exactly. It's all about preservation.
So if we zoom out, what is the big takeaway for the surgeon listening to this?
I think it's about patience and partnership. If you see a type 2 patient, resist that urge for heroic reconstruction. Remember, SNP, wait for the hostile abdomen to calm down.
Okay.
And if you have a type 3 patient, don't just accept that they will be on TPN forever.
Right. Consult the experts. Look into GLP-2. Consider if a step procedure might work for them.
Success changes definition here. In type 2, success is survival. In type 3, success is autonomy getting off the pump. And sometimes the best surgical tool you have is the judgment to know when not to cut.
A powerful place to leave it. We hope this framework helps you navigate these incredibly complex cases.
And hey, if you found this deep dive useful, please do not forget to share it with at least one of your colleagues or friends. Send the link to your resident group chat. Spread the word.
And check out our YouTube channel and other social media pages. We'll have some diagrams of the step and Bianchi procedures up there because, honestly, you need to see the origami to believe it. Thanks for listening, and we'll see you on the next deep dive.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.